that brings us on to another aspect that it would be really good to discuss, because oftentimes people would say to me, well, okay, I've developed type 2 diabetes, let's say. Why do I now need to have treatment for my cholesterol? Why do I now need to have treatment for my blood pressure if they weren't on blood pressure treatment before? And I would say that it's about decreasing risk, decreasing the chances of you developing complications. But I think if that explanation is not given, people don't understand. I'm going to use the term that we did at the beginning, cardiovascular risk, and how you're reducing it by controlling the blood pressure, by making sure that the cholesterol levels are optimized as well. Do you want to say a little bit about that?
Yeah, so the best analogy I can give is a 60-year-old Dave from Dagenham who, comes into hospital with a heart attack. Now, a heart attack means that at some point, one of the main arteries that supply blood to the heart muscle, due to all that clogging up we've been talking about, clogs up permanently. They suffer quite a severe symptoms, and somebody brings them into hospital. The goal is to find which artery is blocked and then try and open it up. Now, following opening it up, we sit them on the ward and we say, we're going to need to treat you to prevent this from happening again. So this is where the term secondary prevention comes into it. So we want to prevent this from happening a second time. One of the things that we need to do is to control your cholesterol, because high levels of cholesterol can cause the clogging up and then you having a heart attack. But then the patient says, I see my GP twice a year. In fact, the last time I checked my cholesterol, it was 4 or it was 3.5. Now, this is what I say, which is why when we were talking at the start, we're talking about various factors that could increase risk and, things like, race and ethnicity and various things like that potentially, which I'm sure we'll talk about later. It's about understanding what the situation for each individual patient is. So what I say to them is, well, your cholesterol was 4, but you still had a heart attack. That means 4 is too high for you, Mr. John. 4 is too high for you. 4 might be okay for somebody else, but 4 is too high for you because it's enough for you to develop the problems that you have developed in terms of coming in with this heart attack. So when you see a patient with diabetes and they've got all these other secondary medical problems or comorbidities, you do have to be aggressive in treating those things, because for that patient, those things will exponentially increase their risk of developing a complication.
Absolutely. And I mean, from a secondary care perspective, you're talking about secondary prevention, because Dave from Dagenham, as you described him, has come into the hospital, unfortunately, and had a heart attack. From the primary care perspective, when we are sitting in primary care, so people would know that as general practice or a community clinic, perhaps, that is a more difficult thing to explain, because the person with you has not, thankfully, had one of those serious complications, and you're trying to say, we need to do X, Y, and Z, and that may be having some treatment for the cholesterol, or trying to get the cholesterol down in some other way, trying to get the weight down, perhaps, trying to get the blood pressure down, because we don't want those complications to develop. We don't want that person to be ending up on your ward, in your clinic. As much as Dr. Henry, you're fantastic, we don't want them to be doing that. We want to avoid that. So let's perhaps talk about how people can avoid atherosclerosis, cardiovascular disease, heart disease of its various forms. What preventative things can they do? And then I think I'd like us to talk on specific groups.
Yes. I mean, so just to re-clarify, you're absolutely right. Dave from Dagenham, who comes into hospital, has had a cardiovascular event, whether it's a heart attack, whether it's a stroke, whether it's development of heart failure, it's happened already. So everything you're doing at that point is to treat the new condition they've had and prevent them from having more complications. However, Sue from Southampton maybe has come into your clinic and they're overweight, they are a 5-a-day cigarette smoker, and they've got a blood pressure that is just above normal. They've not had a heart attack or stroke. And in fact, if you took an ultrasound probe and you scan their heart is going to pump with the required amount of blood every single beat. So nothing bad has happened, but something bad is going to happen in the future, almost certainly, if they do not curtail their lifestyle. There's no magic about it. You want people to obviously avoid adverse lifestyle habits such as cigarette smoking, pack it in. If you did that over the next week, you'll immediately see a change in the way the platelets are a blood product that contributes to this developing of hardening within the arteries as cholesterol builds up. They get more sticky in people who smoke. As soon as you stop doing that, that's out of the way. Okay, so that's one good thing to do. Exercise. Now, people think, oh my God, I really can't exercise because that's like going to train for the Olympics. I haven't got that in me. Well, nobody's asking you to do that. 30 to 60 minutes of of exercise that makes you sweat, is what I say to my patients. Exercise that makes you sweat, do lots of aerobic exercises if you can. Strengthening exercises are good, but 30 to 60 minutes, in total, if you did that every other day. Okay. Now, I'm avoiding what is written in all the literature that's very prescriptive, and I'm avoiding when it comes to exercise, saying specific things, because I think that it puts a lot of people off. It puts my patients off. I've had patients who have said, unfortunately, I can't operate on you because of your weight, and not because of the weight itself. I could. The problem is if there's a complication that occurred, I don't have a needle long enough, that will help me prevent death on the table. So regular exercise. What about meals? Okay. Now, again, you could do a Google search of what, nutritional advice is out there. And there's, my goodness, all sorts. Now, naturally, of course, in a patient who has got diabetes, you've got to be cautious about how much sugar you've got, but we're talking about a patient who hasn't had diabetes yet. So what you want to tell them is to eat a balanced diet. I use the palm of my hand as a good as good advice. You look at the palm, the circle of the palm of your hand. If that's what your meal portion size looks like, it's unlikely that you're going to be taking in excessive calories. And remember, just because I say the palm of my hand doesn't mean it has to be piled up all the way high up there. Okay, it's just got to be, reasonable. And in fact, patients come back, and I'm sure you would have seen that in your practice, Dr. St. John, where patients come and they start to topple over and they're falling over, and you realize, well, their blood pressure is much better controlled because they've lost so much weight. They don't need all these tablets anymore, you see. And that is where you start to bring in the term remission. So hypertension is in remission. You can bring things down. Your diabetes can actually be in remission because you can start to cut down on tablets you're taking if your lifestyle actually changes.
Okay. And are there specific preventative strategies for people, let's say, who self-identify as Black?
Yes, I mean, I think it's education, Dr. St. John. It really is. You find that people who suffer more complications or develop more cardiovascular disease are more likely to have poor socioeconomic status, poor education, poor income. And these are the people who are more deprived, whatever deprivation index you use. And these are the people that we need to target the most in terms of primary prevention. That is, this is a patient who hasn't yet developed the condition. They've not developed it. You can stop it from happening. See, the problem with telling somebody who has no symptoms, who feels completely well, that they should do things to stop them from preventing something in the future is very, very hard. And I'm sure you must, have that experience. It's very, very hard. That's why primary prevention is very hard to achieve. It's still, the goal, but the investment into going in and educating people and providing programs that will help them with structured weight training or structured nutritional training and all those things, and structures that will help to commit people to doing these things as well, for their long-term health, is very, very difficult. However, it's not insurmountable, the problems. And I think that things like this webinar is very, very important to help people see that, well, there's a problem, we should do something about it. I should try and see if I can prevent a problem from happening in the future.
That's excellent advice for somebody who may be living with any of these conditions. And finally, can I ask, is there any other advice you would give for healthcare professionals, and if you want to give any other advice to people who may be living with one of these conditions as well?
So I for patients first, okay? Now, the one thing I always say, because I look after probably the sickest group of patients in cardiology, these are patients who have developed heart failure. Now, heart failure is an unfortunate term, okay? But it's a term that describes somebody whose heart isn't pumping as strongly as it should, as I explained earlier. And people in the past, the mortality, or the number of people who will die following a diagnosis of heart failure, was almost half over a 1-year period. So 100 people who have a new diagnosis, unfortunately 50 of them will be dead before the end of the year. In fact, heart failure, survival for heart failure at 5 years is worse than many of the solid organ cancers in both men and women outside of lung cancer. However, we have therapies that are proven and that can reduce this risk so dramatically. I have lots of patients who live full length of their lives and who enjoy living their lives, because it's not enough to have a quantity of life. You've got to have some quality to it. Take their grandkids to school, still go doing half charity runs and things like that. So the thing about living with a long-term condition is that, number one, you need to equip yourself with the education to be able to try and deal with it. And for healthcare professionals, so there's hope. There's a lot of hope. There's a lot of hope out there. You shouldn't be despondent. There's therapies, and if you're in a disease management program with committed healthcare professionals, you will live the full length of your life. You will prevent complications. Not every diabetic patient needs to have, become blind or have an amputation or develop kidney disease or require kidney transplant. None of those things need to happen. So the hope is there. But for healthcare professionals, this is where the work is. The work is there because we need to change the way we communicate with our patients. We need to make things clearer for them to understand. We need to give them the time of day. Now, of course, it's a pressured system that we work in. However, we can change the way we work so that we can provide this information, because it's like preventing a problem that we are going to need to deal with in the future. I think a lot of communication has to change. Clarity has to be provided for patients, and the onus is on us, because that's what we signed up to.
That's absolutely brilliant point to end on. Our challenge to communicate with clarity. So many thanks, Dr. Savage. I really appreciate all the advice and information that you've given us. And we're going to have the live Q&A, and I'm sure there'll be lots and lots of questions. So thank you very much.
Thank you very much, Dr. St John.